Hi, everybody. This is Susan Clinton, one of your hosts from Tough to Treat. In this podcast, it's a rebroadcast of a podcast we did a few years ago about looking at left lower quadrant pain, eliminating the musculoskeletal contributors, and really when we eliminate the possible and the probable, sometimes we have to look to what the improbable or the impossible is. This is a story of a um, client who had a lot of left lower quadrant pain, and as you listen through the clinical reasoning, you understand that the nociceptive input was coming from a visceral driver and not necessarily from a musculoskeletal driver. I appreciate your listening. We're excited to be rebroadcasting for you this summer, giving Erica and I a bit of a break, and we will be rejoining, of course, in the fall. Enjoy the rebroadcast of this podcast. It's a really good one that probably has been buried in the archives for a bit. Thank you very much, and we'll see you soon. Hi, everybody. Welcome to Tough to Treat. I'm Susan Clinton, your co-host, along with my co-host, Erica Mello. Hi, Erica.
Hi, Susan.
So let's just talk about what we were going to talk about today for this podcast. Let's dive right in.
Let's do it.
I chose this one. This has been a complex patient that I have treated in the past, and very interesting presentation. But it also, I decided, it also became kind of a little bit of a learning tool, I feel like, for people as well. So I'm just going to dive right in. You know how we always talk about looking for drivers and kind of what's going on. This is one who has a few things that are happening all at one time, which kind of made it interesting, but also very frustrating for her because nobody was really helping her put the whole picture together. So this is a 67-year-old female, a very, very highly cognitive functional individual. I'll leave it at that. You know, very smart, still working, very, very engaged in her work. And she's also somebody who's very slight of frame, you know, she's just not a big person. She's just a little tiny person, very strong, very healthy, individual. She had been told by a couple of people to find me, and she presented with kind of an interesting combination. She first started telling me about pointing to her right perineum around her ischial tuberosity. So she would trace the entire ischial tuberosity. Then she would say, and then I have a hamstring issue. It's like, how do you know you have a hamstring issue? Because an MRI showed tears and degeneration at the hamstring tendons in my pelvis. So part of the hamstrings, attach up into the sacrotuberous ligament. It's not, she's 67. This is not an unusual presentation on MRI. But
right.
It's in her brain, of course. And that's what she was told. So she, really had no reason to question it. And then, so she, the biggest thing was, though, this is just around my perineum, around this ischial tuberosity, especially when I sit. And, and I think it's because my hamstrings are torn, and, but her so we'll get into that in just a little bit into the exam part. And then, after just kind of listening to her and talking and just kind of getting to know her a little bit better, she started talking about having some left lower extremity pain. So this was on the right, the presentation around the perineum. And then on the left side, she had some what she called kind of vague. She goes, I think I have a disc. And it's like, how do you know you have a disc? Well, I have this kind of nervy pain that kind of comes down the side of my leg. And, but, she goes, I really notice it when it comes down below my knee into my foot. When it's just on the side of my leg, it's not a big deal. But when it comes down, below my knee to my foot, it really bothers me. So, and just really kind of continuing to talk, she said that she'd had the left-sided nerve pain for a while, at least a year and a half. She's had the perineal pain for a little longer than that, but it got really bad a year and a half ago. So I started kind of thinking, it's like, what happened a year and a half ago? Like, what was going on at that time?
Exactly.
Some pretty significant things happened. She had some big issues with moving. There was a lot of stuff around a big move. There was some stuff around a death as well. So there was a lot of big things that happened at that time for her. And so we just talked a little
Right.
bit about, some other things. Who has she seen? She saw a urologist, she saw a gynecologist, she recently saw a urogynecologist, she has seen an orthopedist. And she said, I really have spent most of my life not being ill, and now I have all these problems. And I said, well, tell me about your other problems. And so she talked about, you know, um, having some constipation and some things like that, and that the urologist put her on Detrol because she goes, I feel like I need to go to the bathroom all the time. And I said, how long has that been going on? Well, that
Mm.
started. She, her story was that started about a year and a half ago.
Ah,
Same time
same
everything else
time.
was going on. And so, when you hear the words, and some belly pain and, just the whole thing kind of starts to really sound, and if you look at that central sensitization inventory, or what we call
Yeah.
nocioplastic pain now rather than nociceptive,
Receptive.
could
Yeah.
have had a nociceptive beginner, but it was very nocioplastic the way it's behaving. And she has those markers that are in there for that. So, I just kind of started asking her some questions. When did this all start? And so she started telling me this story about how she sits on her chair and that she would deny herself the ability to go to the bathroom. That went on for like about 20 years until the end of the day. And then she would have to like literally press on her perineal area in order to kind of release enough so that she could actually go. And now, of course, the opposite has occurred. Is she's gone into where her bladder is, she's got this urgency frequency. So she feels like she has to go all the time. And that's why they put her on the Detrol, which probably is not helping the constipation issues, of course, either, because it can be
Right.
a constipator. Um, so,
Wow.
yeah, so we have a lot here to kind of unpack and talk about. But the biggest thing was, listening to her story, we're thinking, okay, so she needs some bladder voiding. We need to do a bladder diary. We need to kind of see some of these other things that are happening, but it's pretty, it was pretty clear to me that I don't know where this may have started, but it started sounding very, very much like a visceral driver to me,
Mm.
which, we don't talk a lot about on the podcast, but we see that
Mm-mm.
sometimes. People can have, illnesses and, things and end up with, belly pain and bloating and IBS, from just the whole system being taken offline for so long. We see
Yeah.
this after chronic injuries and, different things. Really
Could,
a lot of trauma, stuff like that. Well, that,
yeah.
sometimes, the viscera being and dysfunction can create somatic, issues. It can have a somatic presentation as well.
Yeah.
And, it started to kind of sound a little bit like that with me, but I started with the
Could she?
movement system. Go ahead.
Yeah.
Yeah,
Yeah.
please.
No. Could she sit okay? Could she sit down
Hmm.
with? She could sit. Okay. So she had no
She didn't
problem
like it.
sitting hard.
Yeah, she
She
didn't
didn't
like
like it.
it. And if
Okay.
she was already hurting, then sitting was a real problem. So here's when
Okay.
sitting's the worst. Sitting is the worst when she sits too long
Mm-hmm.
and when she drives.
Okay.
Yeah. So,
Driving and sitting too long.
yeah,
Okay.
right.
Got it.
But here's the other part of the story. I don't know how long is too long because, if I sit, when I sit, I notice like the next day it'll be bad, and then the next day it'll be worse, and the next day it'll be worse. So it starts to sound a little bit like it has an immune type of piece to it, which is,
Mm.
that's the people who exercise and don't know, they feel okay when they're exercising, but 2 hours later they don't feel good at all.
Right.
Like their symptoms really increase. That's the immune response, that happens there, which is very typical when you have the nocioplastic type of stuff going on. And there's a lot of
Yeah.
things that were happening for her all around that one time that, maybe this would have come on anyway, but it definitely got exacerbated about that, year and a half mark when all of those things were converging at the same time.
Yeah. So what
Um,
makes you think so? Okay. Go ahead. Keep
no, go
going.
ahead, go ahead and ask.
No. So what makes you think it was visceral? What clues in her story?
The clues in her story about not allowing herself to urinate and then having a very difficult time urinating,
Mm.
so it's like, so her bladder was being taught to act in a way that is not usual or normal for bladders to behave. But it's what we see with nurses and school teachers and healthcare providers and,
Right. Right.
people who just don't take the time or don't feel like they have the time not even a
Right.
minute to go to the bathroom.
Right.
And, that can, and if she had to press on her pelvic floor in order to,
Mm.
initiate urination, to get enough pressure to get the pelvic floor to probably relax. So it
Yeah.
sounded
Yeah.
like that
Yeah.
her pelvic floor had already started becoming an over recruiter in response to this, this retention
Yeah.
of the urine over the day.
Yep. Yep.
And she said that, when she sits, if she sits in a certain position, she's a very small person, that it makes
Mm.
it worse. So usually when she's like all perched up on a chair with a little bit of an anterior tilt, she feels better if she can grab her right leg and flop it over the side of a chair at home. It
Mhm.
feels more
Interesting.
comfortable. She cannot find a good
Yep.
place to sit in her car. Um,
Mm.
and because that really bothers her. So the first thing that we started doing, of course, I did all the pelvic health things, which was, please fill out this bladder diary, tell me a little bit more about, but try to be as specific as you can so we can kind of see what's happening here. I need a little bit of information about what you're eating. Let's be sure you're chewing your food and getting things in. And, are you doing anything for your constipation? Because that could certainly make this worse. And, so we had some discussions around that and, making sure she's not
Mhm.
eating inflammatory foods. We talked a bit about bladder irritants. She, I sent her the whole list and information on that, and I said, tell me where you want to start with this. Tomatoes were the big thing for her. She was like, that's going to be probably the biggest thing that I'm doing. When I look at this list, this
Uh,
is a big one for me.
uh,
Yeah. So she wanted to start eliminating tomatoes out of her thing, and she knew she needed to start changing her coffee drinking. She was drinking lots
mm.
of coffee during the day,
Yep.
and she's up
Yep.
all night going to the bathroom. And
Of course.
because she's not, was not allowing herself to go to the bathroom during the day. So her sleep was all
Yeah.
knocked
Yeah.
off too,
Oh
which
my
doesn't help
gosh.
when you've got an irritation in there as well.
Yeah.
And so, but so that is there. And, we discussed, alkalizing her water a little bit and, just making the habitat for the bladder a little bit more friendly on the inside. And
Yeah.
then, so where I wanted to go right away was into visceral mobilization, but I didn't because I thought I really need to make sure I'm not missing anything here in this picture. So we did our
Mhm.
normal thing that, we do. I had her stand just normally. And I said, I want you to stand comfortably like you always do. And she was very good at conversation. So she just kept talking and I just kept watching. And one of the things that she did consistently over time while she was standing there telling me another story was that she would either stand and drop into like a really flattened lumbar spine with a really posteriorly rotated pelvis, so super
Mhm.
extended hips, right? But it was almost like the
Yeah. Yeah.
pelvis was
Yeah.
jutted forward, like it wasn't just posteriorly
Uh,
rotated, it was like ahead of her femurs.
Anterior.
Yeah,
Yeah. Oh
her
wow.
pelvis was
Huh.
anterior of the femurs, but still in that posterior. So this jutted forward, kind of
Wow. That's
positioning.
hard to do.
Yeah,
Yeah.
it is. It's really hard to do, but she could do it very well. And then she would switch
Huh.
from that position. She would stand and cross her legs and jut it forward some more. Very small person, so she had, this
Yeah.
kind of
Yeah.
movement. And it was interesting because it was the right side that was jutting forward more than the left
Mhm.
as I
Mhm.
kind of watched this.
Yeah. Yeah.
So I started looking up and I
Uh,
started looking down.
yes.
And one of the things that I noticed was she was really, really, really back on her heels. And she
Of
was
course.
back on the right heel much more than the left heel. So she was really
Huh.
kind of like, like this whole thing, this pelvis jutted forward more, and she was back on that right heel a little bit more. And it caused her thorax to kind of do a little right shift also.
Yeah.
So
Yeah.
I
Yeah.
just
Yeah.
made note of that. And all I did was starting her again with like, let's just do a couple of things right here. She was already irritated because it took her
Mhm.
for, she had to drive to the clinic. So driving was her big thing.
Yeah. Yeah.
So I had her lay down for all of
Yeah.
the
Yeah.
conversation we had so things could calm down. Well, everything's going to bother her because it's already irritated. I
Mhm.
said, okay, I'm looking for things that bother it more. I realize that you have this line of pain that's going
Yes.
on right now. We're
Yes.
looking for things that make it worse. So, I just had
Yeah.
her
Yeah. Yeah.
stand differently. I said, she goes, people have told me all the time to bend my knees when I stand. It's like, okay, well, let's don't do that then. Yes, that apparently
No,
didn't work.
yeah.
So
I ju-
yeah, it's like
I'm just thinking how she can maintain that posterior pelvic
right,
tilt and standing
right.
the whole time.
You know, and so all we did was we just did some things like where are you on your feet, the various stories we've talked about in our podcast. But I basically had to spend some time with her on just kind of, being able to transfer weight off of her heels onto the balls of her feet a little bit, and to really
Yeah,
notice when those gastroc muscles kicked on.
yeah, yeah,
And
yeah.
and she did notice a change in her symptoms, and she wasn't jutting forward as far with her pelvis, and she wasn't doing some of these, and they're just habits. This is classical conditioning at its best.
Yeah, yeah,
She just stands up and this is what she does. She's done it forever.
yeah.
And and then crisscrossing her arms on her chest, kind of the smart girls look, and so we just worked on changing some of that and doing some of that, and that started to make a little bit of a difference with her, which kind of got a really nice entry for her to kind of just like, let's just calm this down, let's do the things that we can to calm it
Yeah.
down, and let's just keep working along this track. That's where I left her that first day, because there was a lot to unpack, and I really wanted her to get her head around, some of these bladder irritants, and to really spend some time filling out a fluid log for me so I could see what was happening. And I told her, I said, don't make it perfect. Just whatever comes up in the day, just write it in.
Yeah.
When you're
Yeah, yeah,
going,
yeah.
count how long you go. You may go 10 or 15 seconds one time, you may go 2 another time. Just write it in. It's okay. It'll help us see a pattern. And I
Mhm.
sent her a bunch of information on that, and out the door she went. But it was interesting because she started to catch on as we were doing the thing, the credit card and all, goodbye, and let's set the next appointment and everything. She caught herself about 10 times going right back into that really, dominant posture that she has.
Yeah,
So
yeah.
yeah, so we kind of got going on that. The other thing that I left her with was, I don't, if it's at all possible, at the end, of 30 minutes, if you can stand up for 5, that would be great. If you can't do that, at the end of the hour, you have to get out of the chair. You
Yeah,
have to
yeah.
give yourself a break. You can't sit for that long, because, we just don't know how long. And so let's try to start exposing, keeping you exposed to sitting, but not 4 and 5 hours at a time, you
I mean,
know?
especially if she's sitting in a posterior pelvic tilt, and hamstrings posteriorly tilt the pelvis too,
Yeah,
you know?
exactly. So anyway, so that's kind of where we left it. So the next time she came in, I did much more of a bigger exam. We did the lumbar flexion, we did a lumbar extension, we looked at the thorax. I looked at, her feet had changed a bit. She was really working on kind of changing that. She was still off on that
Yeah.
right side quite a bit, but not as bad. It wasn't as rotated as it was when she came in the first time. She still had some pain because she had driven to the clinic. And, so that actually I was okay with that, because if we could figure out a way to settle it down, that was a good thing. So through
Mm,
the exam, we examined the hamstrings, we examined the length and the tension and the strength. We did not find any problems whatsoever. Good motor control of her left foot and her right foot. Does she have some sensory stuff? Probably. Yes, she definitely, you could tell that if she spent a lot of time sitting. I asked her, this question, how does it feel below your knee when you're in the car? Oh, it's much worse. How does it feel below your knee after you've been sitting all day? Oh, it's much worse. So we did some extension. She didn't want to do it in standing, and I didn't want to feed into that whole kind of weird postural thing that was going on. So we just got her on the bed, and I said, just prop up on your elbows and tell me how you feel. And that definitely took the pain down that was in the side of her leg. It took it down.
mm,
Hard to tell if it changed the perineum at all. It did change it
yeah,
some, but it was really hard to tell. Again, that
yeah,
immunity thing, after she does something too long, kind of tends to linger. So I said, well, let's figure out a couple of other things then for, because that'll help that pain down your leg. So when you can, if there, let's figure out a way that you can do this after you get out of the car. So I'm
yeah,
putting my thinking cap on, trying to think, how can I do this without her jutting that pelvis forward again?
Right. Exactly.
But in the meantime, I said, I said, let's take a look at, let's just do a, thing and get you into child's pose.
Hmm.
And, so we did, and then we kind of did, with, the heels together and the knees apart. I can think they call that wild child or whatever. But we
Yes.
just increased, like we do with, standing, narrow, wide,
Hmm.
together,
Normal wide.
yeah.
Yeah.
Uh-huh. And so that felt really good. And, I helped her put a pillow in the front of her pelvis as she, went down into that position. We got her to breathe some and relax. And that is when you could really tell that the thorax was really kind of like tilted, the right, kind of right rotated a bit. And I
Hmm.
thought we've got a little bit of work to do in this thorax here. So,
Yeah.
so we did that. And then I taught her how to do the doorknob standing squat, where you hold onto the doorknob with your arms
Yeah.
extended and you do a sit back squat. You go as low as you
Yep.
can. She
Yep.
loved that. That felt
I
really
bet.
good.
I'll bet that was probably good for everything.
Yeah, it felt really good. And so we tried it with narrow, we tried it medium, we tried it wide. She liked wide the best. That was fine with me. It didn't kick
Yeah.
up her
Yeah.
leg, so I was okay there. It actually made her perineum feel a little bit better. So
I
hooray.
was going to say, yeah. Yes,
So then,
exactly.
then the next thing we did, the very next treatment she came in for, so that was the second one. And I will also tell you that I gave her things like cat-cow on her hands and knees. We explored, lower trunk rotations, some different things, but I wasn't quite ready to dive into the thorax with her yet, because there was just, her attention was on the lumbopelvic leg region, and I wanted to keep it there for a bit. Go ahead.
Yeah, Susan, her forward bend was normal. Her lumbar
Yeah.
flexion was
Yeah.
normal. Okay, and she didn't exhibit any kind of symptoms or no like posterior lean or anything like that. Okay.
I suspect that if
Okay.
I put her in
Okay.
that position for a long period of time, it probably would have happened. But I,
Yes.
with
Yeah.
just bending, and I already know that sitting's a problem. And I've already watched her sit. So we're
Yeah,
changing the way that she
exactly.
sits and changing some things there. So the third time she came in, we had the fluid log and we went through it and we talked about how to even this out and how to, slowly hydrate throughout the day and not wait till 4 o'clock and start gulping water, and making some of those changes. But then I wanted to go ahead and do some visceral, just some movement of her viscera, just to see if any of this caused her any problems. And it was really
Hmm.
very interesting. Once there's a technique where you can get, just above the pubic bone onto the bladder, and
In supine,
supine with the
prone.
legs. Yeah, and supine with the legs over a pillow,
Okay.
just comfortable, calm. And, as soon as I started working viscerally with her bladder, or the tissues around her bladder, or the nervous system around her bladder, you can call it
Yes.
whatever you
Yes.
want to call it. But as
Exactly.
soon
Yep.
as I got into that region, that increased her perineal pain.
So your hand was where now, Susan?
So
And
my
she
hand
didn't.
was like, so her pubic bone, you put your fingers on top of the
Yeah.
pubic bone and you just come up towards the belly button so that you're in the soft tissue of the abdomen as it attaches to the pubic
Ah,
bone,
got it. Got it. Got
right
it.
where the bladder lives.
Yes.
So just
Got it.
moving things around, moving neurology around in that area was really
Like,
quite tender, quite significant, and really that brought everything on.
so just like doing a listening with your hands there brought her symptoms
Just
on.
doing some some side to side movement. We call it kind of
Ah,
mobilizing the
yeah, yeah.
vesical ligaments that hold the bladder in place.
Yes, yes, yes. Yep.
So, and then over towards the left of the pubic bone into her sigmoid colon, that was very tender too. You could feel lumps of stool there, so still very constipated. But
Yeah.
a lot of this brought on her left kind of nervy pain,
Oh,
and
interesting.
you have to think about that. The colon is retroperitoneal, and can irritate soft tissues, fascia, nerves, anything. So it was
Yeah,
interesting that it brought on that symptom when we weren't in a position to bring on that symptom. It didn't really go
yeah,
down below
yeah.
the knee, but she said whatever that's making this happen. And so that's why visceral driver. So here's where the story goes a little sideways. So it kind of sounds pretty simple now. Treat get the bladder under control, treat the viscera,
Yeah, with the
get
viscera.
movement there, all this stuff, and life will go on and be good. Well, in the meantime, then there was a break I had to take because I was out of town. And in the meantime, unbeknownst to me, she went to go see another PT, which is totally fine if she wants to go do that. But the other
Right.
PT spent time with her and told her that everything that I had told her to do was wrong, and that she needed to completely quit
Oh,
any exercises whatsoever and only concentrate on her transversus abdominis. This is somebody who walks miles. This is somebody who is very active and very healthy. She's very strong, but she said, your pelvic floor won't get better until we get your core stronger. This is somebody who can
oh my
plank.
God.
He can plank.
Jesus.
She did something. So anyway, so we had it, so I'm putting this out there because if anybody's listening to the podcast, it's like, we really need to meet people where they are and stop telling people to stop doing everything.
Yeah.
Everything.
Yeah.
I am aware her obturator internus is kicked up. That's why she's standing the way she's standing. And, it's one of the muscles that's involved with urinary retention and urgency frequency. I get it. But there's also the viscera that's very, very important too. And the driver was not a musculoskeletal because my core is weak, my pelvic floor is over recruiting. That was not the issue here.
Exactly. It's not an overactive superficial system and an underactive deep system. That was not the driver. That's not the impairment,
Exactly.
so to speak, right?
Right. They were secondary. And we're in a nociceptive type of situation here. So you don't want to take them away from stuff. You want to expose them. You want to be careful. I wanted her to not stop sitting, but I wanted her to sit differently, and I wanted her not to sit so much at a time. And by this time, we've been into this now for about 5 weeks. And by this time, she could tell me very specifically, if I oversit, I'm in trouble. When I do the things I need to do to get up, I do much better. It's driving now. It's only driving that kicks up my pain. Everything else is so much better. And I said, well, then you need to make a decision about which way you want to go. So she, after a while, again, highly cognitive functional person, really wanted to understand why this other person would say this and this, really wanted to open it all up and talk about it. And I was fine
I would have
with
lost
that.
it right there.
I was just like, let's just, you just tell me, what it is. It's okay. And we'll just kind of move on, with the story. So regardless of everything else, she decided to stay with me, which is fine. And we continued down the visceral driver path, but I added in the thorax here. And mainly because I felt like that she was just, and that was the other thing, is that she wanted me to push my belly out when I breathe. And I'm like, if anybody out there knows Susan Clinton, it's like, we want the whole system working. This person is already fighting with it, with this other stuff. And now you want to press on it with extra breath. It's like, no. But anyway, God. I took that as the cue and I said, well, let's talk about breathing just a little bit and let's do this. And so we got her on the wall, because she could feel her back a little bit better.
Yeah.
Thorax on the wall a little bit. We bent the knees, we bent the hips a little bit to take all that other stuff out of it. And, and I said, tell me where you feel the wall the most. And so we just kind of played around with that. And so she kind of got into the thing. And then, because she was doing so good with it on the wall, her breathing started to change anyway, just because she was just in a better position. And, so I grabbed some TheraBand and I said, just grab hold of it and pull it apart a little bit with your 2 hands and just, hang there with it and just keep breathing and see how you do. And then we just got up to standing and did some standing. And then I took the TheraBand away and I said, let's just how are you, where are you with your standing? How's that going? How's that happening? And, so she felt like it. She goes, I still catch myself. I still cross my legs and shove my pelvis forward. And but the way that you got me to change it is still work. So I'm still working on it. And I said, okay, let's do this. Just let's put that TheraBand, grab that TheraBand and pull it apart again a little bit. And and see how that feels in standing, and so that helped. She was like, it feels different. So it's like, okay, so this is good. Well, remember everybody, all of the nerves that come out of the thorax go into the abdomen and down into the lower abdomen into the, there's still, the bladder still has, connections from L1 and L2 and, and certainly the lower colon does. So, here we go. We're right at that area and that junction where that rotation may be occurring.
Right.
But, just being, again, adaptive creatures, we adapt till we can't. And then she had
and also with, and also, I'm sorry, so with driving, she's got her arms on the wheel, right? And so she's probably, I'm just, I'm not gonna harp on the positioning, but when you have your arms involved and, on a close chain, you gotta like explore the thorax just a tad, I think it makes sense with her story.
And part of, I think, the driving issue, as I got to know her better, was she's a very nervous driver. So there's a lot more to that part of the story too, but she's just a very nervous. Driving was not a comfort zone for her. And so here we've got somebody with,
Context.
but no, it was good because we talked about that. I said, I wonder what's happening in the car. So we got back in the car again and, tried to kind of settle her up on more of, she's got a bucket seat. We filled it up with a denser blanket and said, let's try to make this more like a bench seat. And, and just kind of just show me like, which hand do you put on top of the steering wheel? What do you do? And so what she usually does is she would like lean onto her, middle console,
yeah,
a lot. And so yeah,
pattern.
So we kind of talked about, can you lean onto your door, your door handle on the other, the elbow pad on the other side a little bit.
Yeah, exactly.
Just start, kind of, changing things up and trying to help, because it's just going to be, that was like the biggest sticking point still was driving is still the biggest problem. But we got her where she was doing a lot of different exercises. She had some exercises she didn't like. If she didn't like them, we changed them. She took her a while to understand with the cat-cow and lower trunk rotations and movements that don't keep pushing into when you feel that pulling on the left side or this happening here or that happening there. Just stay to the edge of it and, keep moving, but, keep it without going all the way over. She just really needed a lot of redirection and a lot of those things. And we spent a lot of time with that. So by the time I finished with her, it was really, really quite nice. She still has trouble driving, but she's so much better. But all of the other stuff has really markedly improved. And she really started to understand about, I need to hydrate better. I need to, I need to stay away from some bladder irritants. One of the things that I'd like to do with her in the future is see when she talked about wanting to get off the Detrol. And I said, and I think that's a perfect thing to do. You'll let me know when you're ready. And, your urologist, I know her urologist really well. And I said, they would be very supportive of that. It was just there as kind of a bridge for you. And now that you're, you've crossed that bridge, why don't you just wait and see, and let's see how your symptoms keep changing and improving. But, she was also reassured that it's okay to do the exercises that she wanted to do. Those exercises were not bothering her. They were not giving her pain. She was not painful with them. The number one thing that bothered her was sitting.
Right. So you did like the visceral mobilization. You gave her, you worked with her on her center of mass over base of support, getting her more forward. You gave her the door squats, and then you had her do cat camel in different positions of normal, narrow, wide. And then you had her stand with the TheraBand wrapped around her forearms to sort of maybe see how her nervous system adjusted to that position. Is that okay? Yeah. And so she didn't continue to do the abdominal exercises, did she? No. Yeah.
She was fine. She was strong. She could do like a full leg, her legs straight, like lowering down to the bed. She was like fine.
Know. Oh,
so, and it's like, I understand. I totally understand when you do have a real, underlying underactivity of something and the global muscles have taken over. I totally get the where that can work, but this was not the case. This was a case of the drivers were very different here. And, at first I thought there's probably a foot driver in here because of the way she's standing, but it wasn't. Yes. It was definitely it was classical conditioning, but it was definitely this visceral pattern that, for her not to pee, and not allow herself to pee, that probably set this whole thing off. And the thorax was the secondary driver in there. Because she couldn't stay, like I said, and the way that she took one leg over helped her rotate her thorax backwards on the right, right rotation. And so, just doing the other stuff wasn't going to change it. It wasn't going to get her, moving differently over her feet. And it certainly wasn't going to, really take care of the issues that, were happening in the bladder and GI system.
No.
And, but the biggest thing is that, the thorax would have never been treated.
I
And you
know.
can,
And
and you
there's
and
such
I
a
have
strong
talked about this a
relationship.
long time, that people can have a primary and secondary drivers, and they're
Mhm.
going to reveal themselves. If it was not a thoracic driver, it would have gone away once things
Right.
started getting better, right? But it
Correct.
wasn't. It was
Correct.
still there.
Right.
And
Yeah. Yeah.
sitting
Absolutely.
was still a problem, but sitting in the car was really the problem.
Yes. Yes.
And
Exactly.
so really having to get into that was, if we didn't do that, it wasn't going to change anything.
Yeah, it's funny because there's such a strong relationship between the thorax and the pelvis. And do you remember, I forgot what podcast number it is, but I've been, I think it's for the listeners, it's leaking and running. Remember one of my patients we had on, she was postpartum about a
Yeah.
year, Jackie. So for the listeners who start, whoever, if you haven't listened to that, one's called Leaking and Running. I think it's in maybe 40s or 50s or 60s
Mm-hmm.
at this point, but she was also way on her heels, and it's a great another podcast, another episode to listen to after you've listened to this one,
Mm-hmm.
because it puts together that whole center of mass piece as well. It's fantastic. Listen, because it's me and Susan and my patient. So
Mm-hmm.
anyway, that's that's just throwing that out there. It's so fascinating. It really is. And you always think, and she actually had a foot driver, Jackie, because there is that relationship as well. So this is a fascinating case. I've taken some visceral work at the Baral Institute. I've not done the pelvic part of it. I've done visceral 1, BM1, BM2,
Yeah.
and some parts of that. But I think that's just fascinating. And what's great is that if you can still stand in a posterior pelvic tilt, but you need to be able to move out of that position. If you can't move out, and if that becomes your dominant position, that's a problem.
Mm-hmm. And especially
So
because it was perpetuating everything else.
yes,
So
exactly.
and it was hard for her to change it, but she did. She made it through, and she's doing good.
Awesome.
Yeah, we're getting there.
Awesome. Well, yeah, awesome. Well, thank you, Susan.
All right,
This is a great
everybody.
case.
Yeah, we look
Loved
forward to
it.
listening to your comments and your questions. And keep in mind that the subscription to our podcast, which is coming soon, the Tough to Treat Podcast Club, we're going to have every month a live Q&A.
Yeah.
So, and you don't have to be there to listen to it. Send in your questions. We will answer them.
Yeah,
we will discuss
exactly.
them. And if
when
you
you
are
have
there,
and
you've applied
even
in
better.
time, you can we'll have one person do a hot seat. So we have opportunity for more interaction. Mm-hmm.
Yeah, and you can, as part of the membership, you can access that anytime. It's like a regular podcast. It's just going to be a part of you'll have a separate feed, a different podcast membership feed. So more details to come, but that's awesome.
Yep.
Thank you, everybody.